Welcome to Friday morning conference. I am going to give a presentation today that will make sure it runs. I don't have some of the videos that I had wanted because of a computer switch, but that's okay. But we know last minute changes don't always work well, so as I was making changes last night, I was trying to be very, very careful. But I think what we will try and do, we always come to these presentations with an agenda. And mine is to have you think about what it is that you're doing every day when you give a neuromuscular blocking agent and when you choose whether or not to reverse it. I've been in the operating rooms here now for about 2 months, and it's wonderful to see that things can be so different from a place where you had spent so many of years training and then another place practicing. But I think there are ways to move towards evidence-based practice and to consider different paradigms, if you will, protocols for reversal of neuromuscular blockade and monitoring. And we're going to focus on Sugamidex because I think that is the one thing that is really very, very different here that we did not have access to where I was before. Now, we always start these with conflicts of interest. These are remote at best, but Cornell did support a study of a new neuromuscular blocking agent that I did trials with, and Merck is actually currently supporting a study that's housed at Cornell, a database work looking at residual paralysis in at-risk patients. For those of you who have heard talks have been in practice for a while, you may think, well, gosh, why in the world are we looking at this? This is just old stuff. I know what I do. And we all come into work in the hospital every morning planning to do the best that we possibly can to take care of our patients. Well, we're going to talk about this really for a number of reasons, looking at our use of medications here and our patients' outcomes postoperatively. Postoperative reintubations are not uncommon. This institution isn't unique. That's fairly common across the country. We won't have time today, unfortunately, to look at some of that data, but reintubations do occur with certainty. And unless you're looking for it, everybody can say, no, I've never seen a patient that's partially paralyzed. And in fact, 80% of clinicians think that they have never had a patient with residual paralysis. Documentation, though, of the incidence of residual paralysis in the PACU indicates that we all have, regardless of whether or not we do research in this particular area. Here, we are not monitoring depth of neuromuscular blockade regularly, and if we are not recording it on our anesthesia records. The information from the kinematographs that we have does not translate automatically into EPIC, and it needs to be recorded. And it's always important to monitor. Yes, more important to monitor than to document, but without documentation, you cannot justify your choices for reversal or not. So you do need to document what it is that you're monitoring. And we're going to take a little bit of a closer look at the monitors, and I know there's a lot of frustration with them in the operating room. And I can say that my experience is that about 30% of the time they don't work. Which is a real dissatisfier and a disincentive, if you will, to do the right thing. But we'll talk about how we can work with that. Now, Sugamidex has been available here since June, and the use of it has been increasing over recent months. The data that I looked at was through December of 2016. It was dosed correctly in only 54% of patients who received it. So we're going to take a look at the dosing recommendations for Sugamidex and how it should be properly used. And it is recommended for use, or can be used, when neostigmine is ineffective or not completely effective, and that's fine. But if you're going to use it after neostigmine, you have to wait until the neostigmine has had time to have its peak impact, giving it within 10 to 15 minutes of that dose of neostigmine really isn't necessarily going to do the patient any good, may be exposing the patient to increased risk, and we'll talk about why that may happen. And you can see here that 30% of our patients who received Sugamidex after neostigmine had it within 15 minutes of that neostigmine dose. Okay. If anything that I say this morning is not clear or you don't agree, please speak up. We'll discuss it here. These slides are going to be available for everyone after the presentation. So happy to discuss questions as they come up. So again, the goals of the presentation are to look at the complexities of dosing reversal agents. I became interested in neuromuscular blocking agents because I thought it was something I could really master. I thought it was something I could not only understand, but study and do well. And I would say the whole field has exploded since I started doing research in it over 20 years ago, and it is far more complex than was appreciated years ago. We're going to review the monitoring of depth of neuromuscular blockade. We're going to review the recommendations for dosing of neuromuscular blocking agents, just to get a sense of what we do here. How many people reverse all the time? How many people give 3 milligrams of neostigmine all the time? Oh, then I don't have to talk about anything. It seems like you're all titrating your doses. We're going to review it anyway. We're going to take a look also at the pharmacology and use of Sugamidex as a review. Avoiding residual neuromuscular block is difficult. If it wasn't, residual paralysis would not be a problem in our recovery rooms, and our patients would not see adverse effects because of it. Avoiding residual block requires at least 4 things. Have to monitor. You cannot know how relaxed your patient is or how paralyzed without monitoring. It is crucial to avoid overdosing neuromuscular blocking agents, administering large doses or doses of neuromuscular blocking agents towards the end of a surgical procedure. And you will talk a little bit about this later on, but with laparoscopic procedures, robotic procedures, surgeons always want the patients more relaxed. You cannot paralyze the diaphragm unless you completely wipe out patient's response to neuromuscular stimulation. That does not make their surgery better, and it puts the patient at increased risk. We have to give the correct dose of anticholinesterase if we're going to use it at the end of a procedure, and I would encourage everyone to wait a little longer to extubate. Think back for a second. When was the last time you gave neostigmine and waited 10 minutes to pull out the endotracheal tube? Nobody has to respond. I would bet, though, that it is if anybody, a small subset of this group, because as anesthesiologists, we're used to giving medication, seeing effects. We give the neostigmine, we pull out the endotracheal tube as long as the patient's breathing, and we assume everything's going to be okay. That's not necessarily, though, the way things work. The topic is important, and in the past year, it's really received increased recognition in our literature through editorials, original studies, just because of the frequency with which residual neuromuscular block occurs. It is associated with adverse consequences, as I had said. Our monitoring, not that we don't use it all the time, which we don't, but in part that's because our monitors are inadequate. We are maintaining more and more profound levels of neuromuscular blockade, and again, neostigmine doesn't work like flipping on a light switch. Just to give you a sense of the evolution, if you will, of our understanding of the frequency of this. We go back to 1979. I know many of you weren't even born then. Some of us were in high school. You know, we were all different stages of our own development. But in 1979, when the only thing available that were long-acting neuromuscular blocking agents for use, and clinicians were told, do what you can. There were not yet regular monitors of neuromuscular blockade. Okay, we're going to put things into sort of time context here. Clinicians knew that their patients were going to be looked at with a twitch monitor, mechanomyograph in the recovery room, and told to do what you can. In spite of that, 42% of patients had train-of-4 ratios less than 70% when they rolled into the recovery room. And I will bet that not a single one of the clinicians with these patients said, you know what, they're going to be fine, they don't need a train-of-4 ratio of 70%. I think everybody was trying to do their best. They just couldn't recognize that the train-of-4 ratio was in fact inadequate on admission to the PACU. 10 years later, two things had happened. There were twitch monitors available for clinical use, and atracurium and vecuronium had been introduced into practice. And I think you can appreciate on this slide that it seems that with the introduction of atracurium and vecuronium into practice, the incidence of residual paralysis seemed to change, right? Got to be much, much less. Luckily, people don't kind of stop with one study, and others keep doing it, trying to reproduce. And if we look at the progression, if you will, that study was repeated a couple of years later, and similar results in 2000. Here in 2003, the definition of residual paralysis was changed, as work coming out of Scandinavia increasingly showed in volunteers that with train-of-4 ratios of 70 or 80%, patients will aspirate, their swallowing is discoordinated so that they aspirate more. There is a likelihood, that increased likelihood that they will have a postoperative pulmonary complication defined as a new oxygen requirement or a new infiltrate on chest x-ray. So that's when this train-of-4 ratio of 90% as adequacy of recovery of neuromuscular function was really introduced. And then you can see in 2004, 2008, that even with intermediate acting neuromuscular blocking agents, we weren't doing very well any longer. What are some of the consequences? I'm not going to read this list to you, but of postoperative residual paralysis. I had mentioned a couple of them before. I think for those of you who are working in the PACU concerned about patient satisfaction, some of the recent work coming out of Chicago would suggest that patients have prolonged PACU discharge times. They are not as satisfied with their postoperative course for recovery as if their train-of-4 ratio is 90% when they reach the recovery area. This is one of the more recent studies, and really the first large prospective trial done looking at postoperative pulmonary complications, or as Glenn Murphy described it, critical respiratory events in the PACU. They prospectively looked at patients arriving in the PACU. Overall, it was about 7,500 patients that were included as part of this study, whether or not they had residual paralysis. They defined a critical respiratory event as severe or mild hypoxemia, upper airway obstruction, where the nurse or physician in the PACU had to support the airway. Signs of respiratory distress or impending failure, we've all seen it in our patients. Patients complaining of an inability to breathe, difficulty to breathe, or having difficulty swallowing or speaking. And then they also included inability to breathe when asked by the recovery room nurse. And this is what they found. In patients who had any of these symptoms, if you will, of respiratory compromise, almost 74% of them had a train-of-4 ratio less than 70%. In a matched control group who had no symptoms of respiratory compromise, none of them had a train of 4 ratio less than 70%. And when you look at those who were actually fully recovered, very few of those patients had respiratory compromise. And you can see the alternative in the patients who were in the control, not in the control group. This is a large retrospective study that came out of the Harvard medical system with, I think it was about 50,000 charts reviewed over the course of this study. And they were looking for postoperative patient outcomes as they related to the administration of neuromuscular blocking agents. And the overall conclusion of the study, if you did read it, or if you just read the abstract, it was all the same, that administration of neuromuscular blocking agents was associated with worse outcomes as defined by episodes of hypoxemia, requirement for reintubation, and in-hospital death. And in the far right-hand column, you can see what the odds ratio is of those different things. The incidence of an adverse event was related, of a post-op respiratory complication, was related to the multiples of the ED95 that was administered to the patient. They didn't account for the time course over which these medications were administered, but those patients who received more than 5 times the ED95 had an increase in the odds ratio that they were going to develop a postoperative pulmonary complication. When they looked at what was being done with neostigmine in these patients, I think the findings are surprising. Those patients who got the largest doses of neostigmine had the greatest likelihood of having a postoperative residual complication. Speaks to a couple of things. And this is a retrospective study, so all of the problems with the quality of the data and such are part of the work. But were patients getting larger doses of neostigmine because deeper levels of paralysis were being reversed? Were they getting too much neostigmine, more than they needed, causing an excessive amount of acetylcholine at the neuromuscular junction and channel block because of that? Regardless of the reason, there seems to be an indication based on this retrospective data that neostigmine has to be dosed by a certain formula, whatever you care to call it, protocol. And we'll take a look for what some of the recommendations are for dosing neostigmine based on the degree of paralysis that's being reversed. Does anybody here not reverse neuromuscular blockade? Okay. And I sometimes don't now. I used to not more frequently. I think part of the reason, part of the rationale for that, and I would have told you, I've done kinetic studies with these. I know that 2 hours after a 2 times ED95 dose, my patients are going to be fully recovered. They're not going to have enough neuromuscular blocking agent to cause any significant paralysis. There are a few studies that you will look at over the course of your training and your careers that change your practice, and this was mine. This was done in France, where the standard is to not reverse neuromuscular blockade. That's just the standard, or it was, I'm sorry, back in 2003. I think now they're using Sugamidex. And what you can see in this study, and these patients got atracurium, rocuronium, or vecuronium, and the results were the same with all of them. So they're all put together on this one graph here. 2 hours after getting that one single dose of an intermediate neuromuscular blocking agent, same multiples of the ED95 for each patient, 2 times the ED95, you can see that a significant number of patients had residual paralysis if it was defined as a train of 4 ratio of 70%, And if you use the current definition that now has been in existence for years, a much larger population of patients had train of 4 ratios that were unacceptable when they arrived in the PACU 2, 3, or 4 hours after that first dose or only dose of muscle relaxant. So the question then is, do you reverse or don't you, right? And I think it's going to depend. Anticholinesterases are good, but they can be misdosed, and they have a whole host of adverse effects. Neostigmine and either antimuscarinic, you can see all sorts of arrhythmias depending on the ratio that you use of the two. Neostigmine without the antimuscarinic will result in bradycardia, can result in asystole. When there was a shortage of glycopyrrolate and we started using atropine, lots and lots of additional tachycardias followed by bradycardia in the recovery room. Bronchospasm, nausea and vomiting has been attributed to neostigmine, but that's with doses larger than 3 milligrams, and obviously dry mouth, tension on anastomoses, and failure of neuromuscular transmission, or in fact causing what it is you're giving the medication to reverse. Let's see, okay. This is a schematic just to refresh for a couple of seconds on really what it is that we're doing. In the development of neuromuscular blocking agents, you're looking for ways to get rid of these because you want the relative concentration of the neuromuscular blocking agent when compared to acetylcholine at the neuromuscular junction to decrease, right? So if we can create neuromuscular blocking agents that are eliminated more quickly, whether through chemical means or elimination through the kidneys, that's great. We're not there with a lot of the compounds that we're using though, so we rely more on this, influencing the amount of acetylcholinesterase at the neuromuscular junction. And our anticholinesterases actually increase acetylcholine concentration by decreasing its breakdown, right? Very sort of simple, but we're fooling with a lot of pathways, if you will, in order to make patients or bring them back to their normal physiologic state at the end of an anesthetic. So what information do you need in order to determine whether or not you're going to reverse and how you're going to reverse a patient? Yeah, obviously, I mean, a lot of this goes without saying. Pharmacokinetics and the dynamics of the drugs we're using, that's a given. It's like apple pie and motherhood, right? We have to look at the timing of things. I had mentioned before you don't want to give neuromuscular blocking agent 10 or 15 minutes before you're going to be extubating a patient. That just doesn't work, and you're not going to know where you are in terms of that balance with concentration of rocuronium or vecuronium at the neuromuscular junction relative to acetylcholine. Time to end of surgery, it becomes increasingly complex when we're doing laparoscopic and robotic procedures. Transsphenoidal surgery is another one. Patients have to be adequately anesthetized, immobile, and then they have to be awake. Difficult to find a way to do that quickly and effectively. You have to know what the train of 4 ratio is. You have to. And I'm going to leave it at that for the moment. In interpreting what the train of 4 ratio is, you have to consider where it is that you're monitoring. And then you have to give different doses of neostigmine based on the depth of block. Let's take a look at the depth of neuromuscular block. This is an old study done by Jim Caldwell looking at reversal of neostigmine. These patients got 0.1 milligram per kilogram of vecuronium at the beginning of surgery. And then 4 hours later received neostigmine, regardless of what their level of paralysis was at 4 hours. And you can see overall, it looks like, before neostigmine, we're here at 1, 2, 3, and 4 hours. And then 10 minutes later, you can see at 1 hour, there's a marked increase. And these others, it's a little bit more equivocal when we're looking at the average response. To break that down a little bit more, to show you the interpatient variability with neuromuscular blocking agents. One patient still did not have a train-to-4 ratio of 75% 4 hours after that single vecuronium dose. That's my argument that everybody should be monitored even for a long surgical procedure. There were 8 patients who were recovered, fully recovered, who then, when they got that dose of neostigmine, and that was 40 mics per kilo, their train-to-4 ratios fell to less than 75%. When smaller doses of neostigmine were given, no patient got weaker, and that is something that has fueled subsequent studies looking at smaller doses of anticholinesterase to reverse these lesser doses of neuromuscular blockade. Any questions about that? Yes? It's just not needed in every patient. They were using a smaller dose and found this weakening of patients, if you will, who were fully recovered. So if you were to give the bigger dose, the expectation is that that would have been even more pronounced. I've done most of my work with the benzylisoquinolines and was convinced that everybody would recover from cisatracurium in a timely fashion. And this study is a little bit sobering, if you will, because when you look at neostigmine, antagonism of cisatracurium, in a way very similar to that study that I just described, even with this neuromuscular blocking agent, some patients, when they get neostigmine, unnecessarily have this really prolonged recovery of neuromuscular function. And Matthias Eichermann has shown, and this was part of a study of sugamidex versus neostigmine in tracheotomized rats who received vecuronium, were allowed to recover fully, and then received either sugamidex or neostigmine. And in the rats that received neostigmine, there was a decrease in tidal volume and minute ventilation that was not seen in the animals that received sugamidex. Both of them unnecessarily, because the animals were fully recovered. You can use smaller doses of neostigmine and still see full recovery of neuromuscular function within 10 minutes when you're reversing these more shallow depths of neuromuscular blockade. And in fact, the larger doses are probably contraindicated. And here, Fuchs-Buter looked at reversing from a train-to-4 ratio of either 40% or 60%. And that's because these are, when you're monitoring with a train-to-4 ratio, unless the train-to-4 ratio is less than 40%, you can't reliably detect that residual block. So your patient can be 60% paralyzed by the train-to-4, and you can't detect it. Okay? 60% was chosen as sort of the second point at which reversal could be administered, because if you're using double burst stimulation, sensitivity is increased a little bit, and if the fade is greater than 40%, then you can detect it. But it's still not a great marker. But what you can do in looking at these two panels is to see that when giving 30 mics per kilo of neostigmine at train-to-4 ratio of 40%, within 10 minutes, here you go, train-to-4 ratio is back to 90%. And that happens even more reliably when reversing the patient who had recovered more from neuromuscular blockade. Okay? And you can even, in the patients with a train-to-4 ratio of 60%, give 20 mics per kilo. And for the residents who have worked with me, you'll see sometimes I say, let's give 10 mics per kilo if the patient's train of 4 ratio is 70 or 80%. Because then, as long as you're monitoring recovery in terms of the train of 4, you'll know that your patient is recovered. And you can always give a little bit more neostigmine. You can't take it away, as it is with all of our intravenous medications. Assessment of depth of neuromuscular block. This is from an editorial just this past year in anesthesiology. I don't have to read it to you. I'm just going to emphasize the last sentence. You know, we have the technology, we have the tools, we have the information, whatever movie that comes from. We just have not had the resolve to implement this, and the ASA will probably not come up with guidelines for monitoring because of the cost of developing these guidelines. I would expect, hopefully recommendations though, will be coming out in the future. There certainly has been increasing pressure to move in that direction. I had mentioned before that the stimulation pattern is going to give you different results based on what you're looking for. But again, regardless of what stimulation pattern you're using, you have to monitor. And you have to, when you have access to it, monitor quantitatively. Having worked with John Savarese for, oh my gosh, a quarter of a century when I think back on it, we had lots and lots of discussions about this, and he'd say, oh look, there's a twitch, and I'd say, no, there's nothing there yet. You know, and unless we looked at the mechanomyograph, you really couldn't see the response, and you could not tell the recovery ratio in patients unless you were actually monitoring it. And he and I, with probably 100 years experience combined between the two of us, disagreed at least 50% of the time. So you've got the fade and the train of 4. And if your patient is fully recovered and the train of 4 ratio is greater than 90%, that's great. No concerns. You're ready to go. The patient does not need neostigmine. If, however, there is this degree of fade and you can't appreciate it, you've got to reconsider. The problem is, again, you're not going to be able to detect that degree of fade in the response, and that's because these middle two responses confuse us. Much easier to compare the first and the fourth twitch right next to each other without those two responses in between. But that's the reality of the testing. Double burst stimulation tries to move us away from that. Have you ever used that? Yeah. I haven't even noticed on the monitors in the OR if it's an option. But it is, you know, it is something to consider doing if you're not monitoring quantitatively. Here you can see repeated train of 4 stimuli, here and here. And the train of 4 ratio is about 40%. And again, we're not going to be able to detect that by sight or by touch, again, because the degree of fade, even though it doesn't look it here, is too subtle for us to do that reliably. With the double burst, which is what you see here, the response is a bit more exaggerated. We are much more likely to detect that degree of fade in our patients if we're not using quantitative monitoring. So if we're just touching a patient's thumb or looking at it in response to stimulation. And I got ahead of myself. Here we go. Do you have any of these monitors available here? I've seen the ones on the machine, the one on the far right. Yeah, these are all, if I had time, we'd put X's over each and every one of them, with the exception of the Fisher-Paykel monitor, which is, my understanding is, if you have them, you should keep them. They are no longer made. They are no longer repaired. What this one does is to let you know how much current you're delivering so that you can be sure that you're delivering an adequate amount of current to see a response to stimulation. These are, if you will, a second best, but you just dial this up here and you really don't know how much current you're actually giving to the patient. And supramaximal stimulation has to be just that in order to be sure that you're providing enough. And this is another version of the Fisher-Paykel monitor that we used to use all the time. Again, not an ideal monitor at all. This is the acceleromiograph, which is equivalent by all reviews that I have looked at to the kinemograph that you use or have available in the operating rooms here. What this does is it lets you set the current that's delivered just as you can with the monitors you have in the operating rooms here, and it takes all of the guesswork, when it works, out of the train of 4 response. Problems with this are, let me see what I have for the next slide. The digit on which it's placed has to be able to move freely, and there's a transducer that's taped to this side of the thumb. I only had one view here. So if your arm or a patient's arms are tucked by the side, it really isn't a useful monitor. We used to use it a lot on the foot, and I'll show you how we would set that up, because usually you can get to the foot, and if your patient's bed happens to be turned 90 or 180 degrees, you have ready access to that. This is what we have in the operating rooms here, and again, by all reports, it is equivalent to the acceleromiograph, which has become the new standard for those of us who did work with these agents and monitors in the olden days. Not thrilled with either of them. Both will overestimate to a certain degree the degree of recovery. I see heads nodding over here, yeah, and that is true. And calibration of the instrument is crucial when you're starting. Monitoring sites. We can't overemphasize the importance of where you're going to be monitoring. If you're monitoring at the face, and I will be the first one to say yes, that's sometimes all you have access to. You should never stimulate with more than 40 milliamps, because then you're going to be looking increasingly at direct muscle stimulation. And that tells you absolutely nothing about neuromuscular transmission. You should have the electrodes separated as much as is possible on the face, with one just in front of the ear and one far away on the forehead. The monitors that have the 2 stimulating electrodes that you can put right up here by the eyebrow are really not useful at all, because you are looking at direct muscle stimulation. Another alternative is to put one of the electrodes behind the ear, and then you'll see the whole side of the face contracting, which is really, I think, an ideal alternative. Best to get it set up, though, before you give a neuromuscular blocking agent, so that you know what you'll be looking for during recovery. If you're monitoring at the face, dose more cautiously than you ever would if you were monitoring at the arm. And that is because this is old work done by Francois Donati, looking at recovery, onset and recovery of neuromuscular block in really 4 different muscle groups. And this is the adductor pollicis and the response there. You can say, I'm going to point out a couple of things here. Onset is a little bit slower than it is at the orbicularis oculi. And take a look at recovery. Okay? Much slower than it is at the orbicularis. So even if you're monitoring correctly and looking at neuromuscular transmission only and not direct muscle stimulation at the orbicularis, you will be fooled into thinking that your patient is in fact more recovered than he or she is, and you'll dose another few milligrams of the rocuronium. And for comparison, there's the orbicularis oculi. Okay? And I'm going to point out just that these older studies looked at only the first twitch in the train of 4, which recovers more quickly than the train of 4 ratio does. And remember, now it's the train of 4 ratio that is important when we're looking at recovery of neuromuscular function. Monitoring at the arm, most of us do it this way. Can also put an electrode, if there's enough space in between, if you can stretch your wires that far, over the ulnar groove at the elbow, and you look for adduction of the thumb. You can also monitor, though, as I had mentioned before, on the leg. And I've been using the posterior tibial nerve routinely. looking for plantar flexion of the toes. One of my residents said, well, let's try the common peroneal nerve. That's what we used to use in Australia. And yes, that works equally as well. And you can usually find it around the head of the fibula, even in very large patients. So in patients who have a lot of extra tissue around their ankles, where you're concerned about whether or not you're going to be able to get an adequate current to the nerve, you can look at the common peroneal nerve instead. There have only been, for anybody who's interested in clinical trials, 3 studies that I have found looking at the lower extremity compared to the adductor pollicis for accuracy of the response of stimulating these. And the reason we need another study is because one said recovery occurs more quickly in the legs, another said it occurs more slowly, and the third said that it is exactly the same. So there needs to be a 4th definitive study to help define what it is that we can and should be doing with the information that we get from this monitoring modality. What is the impact of monitoring on recovery, on the actual recovery of neuromuscular function? This again comes out of Glenn Murphy's work, and here he has 2 groups of patients, one monitored with accelerometry and another group with just a conventional monitor. No patients monitored with the acceleromiograph had train-of-4 ratios less than 70%, and far more patients who were monitored with the acceleromiograph were in fact completely recovered than those monitored with conventional monitors in the operating room in routine clinical practice. And more recently, Mike Todd, when he was in Iowa, insisted that all clinical cases were done with a quantitative monitor. They used an EMG there, which is different, obviously, than what we use. And this was because of the lack of monitoring or lack of documentation of monitoring and the frequency of reintubations that they had. And within 2 years of requiring that monitoring be instituted, first of all, you can see that 93% of patients were monitored, so it wasn't 100% yet. Patients were fully recovered when they got to the operating room generally, and there were no reintubations in that period of 2 years once the monitoring was up to that standard. So I think that is a pretty robust study because it was done in clinical practice. It would be like us doing the same thing in our operating rooms. We monitor, we document degree of recovery and what we're doing with neostigmine, and then we look at our reintubation rates. And in speaking with him before he left, I think they did have 1 reintubation in the years after 2013 because of inadequate recovery of neuromuscular function, but that's still good. That's far better than the national average for reintubations. Recommendations for dosing of neostigmine. If your patient has no response to train-of-4 stimulation, do not give neostigmine. And that doesn't mean give a tetanus and 2 minutes later see if there's a train-of-4 response, because there will be a train-of-4 response because you see that post-tetanic facilitation. Don't give any neostigmine if there's no response at the adductor pollicis. I don't care what's happening at the face because, again, that's not indicative of what's happening at the thumb. If a patient has 1 to 3 twitches, give neostigmine 50 mics per kilogram. It's a fair dose. And if there's a train-of-4 count of 4, if you can appreciate fade, give a slightly lesser dose of neostigmine, but still give a substantial dose. And then with no fade, Kottman and Eicherman recommended 15 to 25. I think you can go 15 to 30 mics per kilogram of neostigmine based on the Fuchs-Buter study that we had looked at just a few slides ago. And that's if you don't have quantitative monitoring of train-of-4 ratio. This is just with a routine twitch monitor, or if you have the kinemograph on your patients, you're stimulating, you can see twitches, but nothing's being recorded on the monitor. Count the twitches and dose on this basis here. because you can still use the monitor even if it's not working as it should. Sugamidex, I think this has the potential to change our practice, and I'm not saying that it's going to allow us to intentionally overdose our rocuronium or vecuronium and then get out of trouble. It's really not the purpose of it, but it will allow us to get our patients to the recovery room more fully recovered in terms of their neuromuscular function. It is, as you know, a cyclodextrin. These compounds have been around, used in industry for a very long period of time, and a couple of very clever scientists decided to design one of these molecules so that it would completely encapsulate the hydrophobic rings of a steroidal neuromuscular blocking agent and leave the hydrophilic portions out here exposed to the plasma. What this does is essentially adds another limb to this diagram that you had seen before in terms of offering encapsulation as another means of facilitating recovery from neuromuscular blockade. Essentially what the Sugamidex does, it doesn't get into the neuromuscular junction. It stays in the plasma, but by decreasing the free amount of rocuronium in the plasma, it essentially uses diffusion gradients, if you will, to pull the rocuronium into the plasma so that it can be subsequently bound up with the Sugamidex. And that's what you see when you look at plasma concentrations of rocuronium compared to twitch height. Here we're looking at, this is twitch response in the filled in circle. So with an infusion of rocuronium, twitch falls off down to close to zero. Sugamidex is administered at this point, twitch recovers. Plasma concentrations of the measured rocuronium, though, continue to increase. That's because the rocuronium Sugamidex complex is measured as rocuronium. So it looks like the plasma concentrations are going up. So you have recovery in spite of apparent increases in rocuronium. And when you compare it to succinylcholine, as Naguib did in 2007, when given right after an intubating dose of rocuronium for rapid sequence intubation, 16 milligrams per kilogram, results in really rapid recovery. This is a recording from an acceleromiograph. This is spontaneous recovery from succinylcholine in an individual patient. So it actually takes a little bit longer than the Sugamidex rocuronium combination. And it happens quickly, recovery does. I had used it in studies before and was very happy to see that even in clinical practice it works as well as it looked like it would in clinical trials. This is really a summary of a number of different studies looking at reversal from 0.6 milligrams per kilogram of rocuronium. And you can see that the larger the dose, the more rapid the recovery. It works in renal failure, although how's Sugamidex eliminated? Through the kidneys. Over 90% of a dose is eliminated through the kidneys. So its use in patients with severe renal failure, end-stage renal disease, is not recommended. I think there is work being done to see how to dose in these patients so that it can be used, because these are the patients who are likely going to need it more than a young, healthy individual. In our geriatric patients who are likely at risk for residual paralysis, it also works. Seems to work a little bit more slowly than it does in younger individuals, but nevertheless it does work in these individuals. And you can see here that compared to placebo, and this is the kind of data that the dosing recommendations were based on. Again, the larger the dose, the more rapid the recovery to a certain extent. And This is a comparison of recovery with Sugamidex in this line here, with it being administered at this point in time, rapid and complete recovery, and then with neostigmine you can see this much slower recovery over the course of time, with really full recovery not occurring to almost an hour afterwards. You can underdose Sugamidex, and we're all really cost conscious, but if you're taking care of a patient who is large and you need to open up a second vial in order to dose appropriately, do so, because as you see in this slide here, you can underdose and residual paralysis can recur. So these are the dosing recommendations. If you have a failed rapid sequence intubation and can't intubate, can't ventilate, you need to reverse immediately. 16 milligrams per kilogram is the dose. Then there's this whole wide area where, you know, what dose does it really seem that you should be giving? What is recommended in the package insert is that anytime a patient has a post-ischemic count of 1 to 2, where if you're keeping a patient completely paralyzed so as to minimize the possibility of diaphragmatic movement, you can give 4 milligrams per kilogram and see rapid and reliable recovery of neuromuscular function. If the patient has 2 twitches in a train of 4, they should get, or more, they should get 2 milligrams per kilogram. Side effects are, as you see here, commonly described as common problems. One of the things that I think we have to pay most attention to is we maintain light levels of anesthesia, and if you're reversing the paralysis, patients seem to wake up prematurely. They're strong, so they can respond to stimulation, which they might not have been able to do had neostigmine been administered. So that is something to be careful of. You do have to be sure your patients are adequately anesthetized, especially if you're giving the Sugamidex at the end of a procedure but before the surgeons are finished. So what are we going to see in terms of future trends? I think Sugamidex is going to change things. We need to use it smartly, though. I'm not saying don't use it. There are indications for it. I've been talking with David from pharmacy, who is here, I think. I'm looking, but I don't see him. Yeah. To increase the indications for use in frail patients, geriatric patients, but we need to be careful to, again, dose it wisely so that you're giving enough if you're giving it, or if you're giving it after neostigmine, you're sure that the neostigmine has had its enough time to work, because neostigmine does not work immediately. And I encourage you all to monitor all the time. My goal is to make sure that over the course of the next couple of months, I hope, you wouldn't start an anesthetic without a pulse oximeter or an electrocardiogram, that you don't start one until at least you call or send somebody in the room out to get a working twitch monitor, because you have to monitor if you're going to give a neuromuscular blocking agent. And Calibadian is probably the next new thing on the horizon. We'll see what comes of that. It's beginning volunteer trials now. We know a lot more than we used to when these agents were first introduced into practice, but I think we have a ways to go, and certainly our practice has to change to keep up with the growing body of information that is becoming available. And with that, I will stop and take any questions. Harvey.